Jan, uh, esteemed chairperson, Dr. Manoj Babu, Dr. Jayant, my teacher, whom I love, Professor Das, Ashok Das, uh, and of course, Alok Tanango, who forced me to come and give this talk. And I told him that I don't deal with diabetes. I'm a purely clinical immunologist who deals mostly with immunological problems. But lately, as I can understand that the musculoskeletal manifestations in diabetes are pretty common, and they are mostly seen by orthopedicians. They hardly come to a rheumatologist. When they do come, they are almost in an advanced stage, and there is very little we can do about them. And a lot of people even don't know these musculoskeletal manifestations are part of diabetes. Uh, I must congratulate Professor Manisha. I was impressed. Excellent talk, madam. I was pretty impressed with your talk. Now, all of us know, as I've told you, that is a very important manifestation of diabetes mellitus. Now, we see hundreds of patients of different of different diseases, including mostly autoimmune diseases. But when these patients come with problems of the bone or the joint or the muscle, they normally say that we are being treated for this disease by other specialities for large many years. And when we realize that actually is a diabetic, and that has been taken as a separate kind of problem, and they have not been linked, and the whole issue comes to light that perhaps that equation has not been worked out. And most of them receive very little attention compared to the more serious microvascular complications. And I can understand that because they are more serious, life-threatening compared to the musculoskeletal conditions. But these conditions, if they are recognized early, they affect the quality of life quite badly. And if they can be recognized early and you manage them early, you can significantly improve the quality of life. Before I proceed, I must talk about a case where I realized why these cases are missed and why people don't understand the link between diabetes and musculoskeletal symptom. This guy came in December, mid-December to us. He was from Pune. He's a Air Force person. He came, he showed a lot of people there his problems, like he had swelling of fingers of both the fingers, both the hands, difficulty in making a fist, and there was tightening of skin around the fingers for 6 months. And for this reason, he has gone around multiple specialists, including orthopedicians, and he did not get any relief. He was diabetic for 20 years. Very, very important clue there. He had coronary artery disease 2009 and has been put on a stent. He's on medication, mostly oral diabetic agents. I don't know his HbA1c and all that is not available to us. Blood pressure was 130/80. And the musculoskeletal examination showed no tenderness of the joint, but only swelling of the joints around the MCP and PIPs. Other systems were normal. Now he has been subjected, he has gone from Pune to Delhi, and then because he stays in Orissa, he landed up in Orissa and has been investigated extensively at Bhubaneswar, seen by physicians, orthopedicians, and even rheumatologists. And the spectrum of differential diagnosis was from rheumatoid arthritis to connective tissue disease to scleroderma to multiple myeloma to chronic regional pain syndrome. You can see the wide ranging, and all that you see, his fingers were quite puffy and the skin was tight, and he was unable to flex his fingers. Now, these were the investigations done from outside. That's what he showed us. His CBC was normal, urine was normal, ESR CRP was within normal limits, and they've done the rheumatoid factor, anti-CCB, HLA-B27 were normal. I couldn't figure out. ANA has been done, which is normal. ANA profile was negative. Serum membrane was normal. The kappa lambda beta 2 microglobulin levels were normal. Then they did the X-ray chest, hands, normal. MRI showed only mild septinous edema on the palmar aspect. MRI spine, MRI pelvis, CT thorax. You can see the extensive investigation that he has been subjected to, and most of them had normal results. Then he went through another series of investigations. Vitamin B12, 105 picograms. He was given vitamin B12. His prostate-specific antigen was done. Serum cortisol, morning samples were normal. The CT scan of the whole abdomen has been done. DEXA scan has been done. Upper GI endoscopy showed fundal erosions because he has been taking anti-inflammatory drugs for a long time. Echo was normal. And most people came to their wits' end. And one of the rheumatologists advised that you need to have a flexor tendon biopsy and MDP bone scan. That is where he, almost like the last straw on the camel's back, he ran away and came to us. He came to a rheumatology OPD on 22nd December 2022. We examined the way we do for all patients who come with rheumatological problems. A simple test that we did was what's called a prayer sign. It demonstrated a classical prayer sign. There was no tenderness of the joints. And this is one of the classical presentation of what is called a diabetic chiroarthropathy, stiffness of the joint, stiffness of the skin, otherwise called limited joint mobility syndrome. He was counseled, he was extremely relieved and advised to have physiotherapy and perhaps analgesic and nothing more because there was no other drug to control his diabetes as far as practicable and do physiotherapy. Now, this case I presented to show that he has gone around multiple places. From Pune, he went to Delhi, he went to Calcutta, then he came to Odisha, Bhubaneswar, and has been seen by so many people. People have thought of so many things, have been investigated such widely, but the link between diabetes and this condition has escaped because sometimes it is told what the mind doesn't know, the eyes cannot see. There's an example of that. And by simple counseling, he was so relieved that he blessed us a lot and went back. This is just to suggest that we have very important musculoskeletal manifestation of diabetes. It will group them into 4 groups like soft tissue involvement, joint, bone, muscle involvement. The first group, that's the soft tissue, are the most predominant. We see limited joint mobility syndrome, which I showed, chiroarthropathy or diabetic stiff hand syndrome. And the other one is the last, which we see adhesive capsulitis or frozen shoulder. And carpal tunnel syndrome is pretty common. Stenosing tenosynovitis or trigger finger is equally common. Dupuytren's contraction is not that common. But we do see, but most of them, they are treated by orthopedicians and other specialties, and they rarely come to us. In the joint, the diabetic neuroarthropathy, that's the Charcot's arthropathy, is not very common. Recently, we published a series of 4 or 5 cases of Charcot's arthropathy of the elbows, which is very, very uncommon. And some of them had syringomyelia. Gouty arthritis, it's supposed to be an association with diabetes because of the metabolic syndrome hyperuricemia. And the other 2 conditions, the bone osteoporosis and fracture, very important because in diabetic, having fracture can lead to big problems in management because of multiple complications. And it's been seen that fracture rates, fragility fracture rates are very high in diabetes. A very interesting disease, what is called diffuse idiopathic skeletal hypostosis. I'll show you a picture how they are misdiagnosed as cases of ankylosing spondylitis, but they're very well linked or associated with diabetes mellitus. And lastly, the muscles are involved. Diabetic amyotrophy previously was supposed to be a neuropathy. It is neuropathy. Now we talk about diabetic sarcopenia, extensive loss of muscle in diabetics for reasons not known. And last but not the least, again very rare, diabetic muscle infarction or diabetic myonecrosis. I've seen most of these cases. I've not seen a case of diabetic muscle infarction or diabetic myonecrosis. So this is to suggest that if we have in the mind that diabetes can give rise to this condition, I'm sure we can help a lot of people before they come in a very advanced stage. Very important because we have to understand the pathophysiology of this condition, then we can target the pathophysiology by which we can prevent progression of this disease. As usual, since most of us understand it's presumed in the multifactorial, you have a genetic predisposition. Some people develop these conditions faster than the others. Some people don't even develop. So obviously there is a genetic we do not know. Even the GWAS studies hasn't shown much. There's a microvascular impairment, and there's most important, the accumulation of advanced glycation end product. This is supposed to be the most important aspect of the pathophysiology of musculoskeletal disorders. I think it's true for most of the complications that we see in diabetes. The oxidative stress, reactive oxygen species, which is generated, causes damage to the cells. And of course, diabetic neuropathy, which contributes to Charcot's arthropathy. The fibroblastic proliferative disorder, the soft tissue, which I was showing as the most common in diabetes mellitus, has been worked up a little more than the other conditions. The abnormal accumulation of AGE, which I showed, is one of the most important factors. And this collagen tissue, especially with which fibroblastic proliferation associated with, is very susceptible to glycation. And tendon AGE cross-linking reduces sensitivity to collagenase, so there is less turnover, remodeling capacity is reduced, and it increases stiffness. Interestingly, AGE enhances transcription factor NF-kappa B, resulting in high TNF-alpha and IL-6. So this is where the immunologist is perhaps linked with the diabetologist in regard to the musculoskeletal conditions. Otherwise, we know immunology has a big role to play. Inflammation has a big role to play in diabetes. So the cooperation between an immunologist and a diabetologist will be something that we'll see in the near future. And last, increased ROS triggers inflammatory response and induces cell damage. So all of them, the soft tissue component that we see in the majority of musculoskeletal disorders associated with diabetes is related to AGE and its downward cascades. Now, the prevalence, as you can see, this is something that people have been done by epidemiological studies. All that I wanted to say that these disorders are much more in diabetics compared to non-diabetics, whether it's adhesive capsulitis, frozen shoulder, limited joint mobility, 25 to 76%. This diabetic cardiomyopathy is invariably misdiagnosed as rheumatoid arthritis or scleroderma. That's where people make a mistake. Dupuytren's contracture, there are many other conditions, but here the rates are very high. Carpal tunnel syndrome we see in many conditions. Of course, diabetes is one of the more important factors. Flexor tenosynovitis. This slide suggests that we do see large number of musculoskeletal problems with diabetes. This is the first one, that is the adhesive capsulitis, which we see. It has a progressive painful restriction of shoulder joints. Lots of people come to us with this after they have shown the orthopedician and nothing has happened. And we say, are you a diabetic? Yes, sir. Did you tell this history? No, sir. You should have told the history and it would have been very easy to make a diagnosis. And here, especially the abduction and external rotations are pretty limited. Sometimes you can make a mistake of just the rotator cuff tendinitis. The cause is proliferation of fibroblast, myoblast, collagen. It has 3 phases. Initially, painful phase. This is where you should catch them, find out their sugar levels, see whether they are controlled or not. As Dr. Manisha was telling, the control is so vital, so vital, and that if you don't control it, you have the downward cascade going on. Then you have the adhesive phase. Then it becomes very difficult to treat them because they are so stiff. You have to inject or you have to do surgery. Then the resolution phase. Some of the patients do resolve over time by just physiotherapy and analgesics or NSAIDs. The other one is the chiroarthropathy, which I showed. These are the typical 2 signs that we can do in the clinic to see. One is the prayer sign on the left side. The right side is called a tabletop sign. The fingers cannot be opposed to the table. These are mostly painless progressive stiffness. Fixed flexion. That patient which I showed had this exactly. Fixed flexion contracture, decreased grip strength. And the skin of the hand is waxy and sometimes it can be stiff. So we make a diagnosis of scleroderma, which is wrong actually. The diagnostic tips are prayer table sign. Very simple signs. You don't need great investigations for this. Treatment, controlled diabetes, physiotherapy, and this. In fact, as you see, most of this condition requires simple interventions. Control of diabetes is primary, physiotherapy, analgesics, sometimes analgesics and steroid injections. Very common, we see trigger fingers and then we realize that he's diabetic. Dramatic response, just inject the tendons, they have dramatic response. But again, they come back if the diabetes is not controlled. It is caused by inflammation attributable to repeated friction between flexor tendon and sheath. Interestingly, one has to remember, it affects the thumb, index, and middle, not the other 2 fingers. If you keep that in mind, you can pick them up. Bilateral, most common in women. Physiotherapy, local steroid injections. And Dupuytren's contracture, they come at this stage pretty late. They are slowly progressive fibroproliferative disorder of the palmar fascia, joint stiffness, loss of full extension, palmar digital thickening, tethering, contraction of 3rd, 4th. There you saw 1st, 2nd, 3rd year, 3rd, 4th, and it is mostly progressive and very difficult to treat this patient. Very difficult. At this stage, one has to do a fasciotomy or fasciectomy in surgery. Again, they come back. Now, when you come to the joint involvement, Charcot's, as I told you, related to the neuropathy. Gouty is more like an association because of her metabolic syndrome. And recently, I saw a couple of papers that showed high incidence of osteoarthritis and rheumatoid arthritis in diabetes. And they are mostly associational rather than cause and effect. You can explain by many ways, but cause and effect relationship has never been shown. And Charcot, this is how they come. This is one of our patients, a progressive painless joint destruction. So there are multiple factors involved in this: the mechanical factor, vascular factor, neuropathic factor, and of course, the inflammatory cytokines add to that. Because of repeated trauma, increased laxity, there is fragmentation of articular cartilage and collapse of the bones. Weight-bearing joints like foot, ankle, knees are very important. We got elbow joints because he had syringomyelia. X-rays, very quickly you can catch MRI of the affected joints. Rarely we need, and you have to do a differential diagnosis of septic arthritis and osteomyelitis. Now, the simple X-ray shows you fragmentation and collapse of the bone in Charcot's. Diagnosis becomes very, very simple. Now, this is gout. Most of us must have seen. Now we are seeing increasing number of gout, perhaps diabetes associated with them. A lot of people with diabetes have gout now. Part of the metabolic syndrome, hyperuricemia. More than 9 we treat. Unless it's symptomatic, we don't treat. Asymptomatic, more than 9 we treat. And the concept that diabetes increases risk of gout still remains controversial. However, a 3 years community-based study revealed that 16% of patients with diabetes develop gout compared to 2.7%. So there's definite interlinking between them. But again, cause and effect relationship has not been established. Bone involvement, this is very interesting. Osteoporosis and fragility factors is something we should be aware of in diabetics. And the other one is called DISH, that is the diffuse idiopathic skeletal hyperosteosis, something where the diagnostic skills are tested of many of the physicians. So osteoporosis, most studies have reported increased fragility fractures in diabetes. But the BMD on which we base is low in type 1 diabetes, but very high in type 2 diabetes mellitus. Normally, you see a high BMD, and still they have fractures. So we know fractures have two components. One is a BMD, other one is a microarchitecture. It is believed that in type 2 diabetes, even if the BMD is high, the microarchitecture is defective. Therefore, you get more fragility fractures. And most of the community-based observations have shown that fracture risk was 24 to 63% higher in patients with poor glycemic control. Again, we come back to the same topic of glycemic control. The risk of hip fracture in patients with more than 10 years of diabetes is almost 1.19, and diabetes-related complications increases risk of fracture. Very, very important, because I know most elderly people live for long years. They become old. We have a huge elderly population. A lot of them have diabetes. And they'll get a fracture, and it is horrible treating them. And they're very, very difficult to treat. And since I told you type 2 diabetes have high BMD, what is the method by which you can say these guys have a risk of fracture? Now, how do we test for fracture? How do we test? Now, sorry, I forgot this. Sodium glucose co-transporter, which now the previous speaker was talking about, a very important drug which is being used. This was shown that what the relationship between the SGLT and type 2 diabetes and fractures. A meta-analysis and randomized controlled trials have shown there is about 78 RCTs, 85,000 patients showed that canagliflozin seems to increase the risk of fracture, while other SGLTs do not result in higher incidence of fractures. This is a new drug people are using. This they have to understand and remember. Now, what's the mechanism of fractures in diabetes mellitus? Again, same thing. Based on multiple factors, bone intrinsic factors like accumulation of AGE, low bone turnover, changes in bone microstructure, which I believe is type 2 diabetes. And there are extrinsic factors, the other complications like peripheral neuropathy, hypoglycemia if the patient on insulin, muscle weakness because of sarcopenia weakness, and visual impairment, the trip and fall. So fall is a very, very important concept in fractures. Assessment of diabetes type 2, most of the other ones you can make very clearly. DEXA and FRAX are very good, but here is the problem. The DEXA is high, FRAX cannot tell you without the normal DEXA. So the assessment is difficult. So the two other things have come in, what is called a trabecular bone score. It's based on a DEXA, but on the lumbar spine, and it's based on some calculations where you can do what is called a trabecular bone score. There's no porosity of the trabecular bones. The other one is called a quantitative CT. This again deals with the peripheral bones, and they can suggest possibility of poor microarchitecture in the bones. Otherwise, these two are rarely done in India. Microindentation, you see what is the resistance of periosteal bone when you put a probe in, that suggests poor microarchitecture. And of course, biomarkers, there are several, but very, very expensive. We rarely use biomarkers in our practice because of its cost. So these are things, but two things, the history of diabetes type 2 And then if you can do a trabecular bone score or a quantitative CT, which is available, you can suggest. And so what we need now is a better stratification criteria for diabetes fracture in type 2 diabetes, and also how to deal with these patients when they do not have a low bone density. This is called DISH. And as you can see, those bones protruding out, they look exactly like ankylosing spondylitis. The patient comes with very, very stiff back, cannot bend forward. But the beauty is it is very thick. These are osteophytes, actually, calcification and ossification of anterolateral ligament spine. Prevalence is very high in diabetes, 5 to 50% higher than general population. Patients have stiff spinal stiffness, low backache. So easily, I've seen hundreds of patients. They come with us X-ray like this and say they have been diagnosed with ankylosing spondylitis. Although there's no feature, doesn't fit into the classification criteria. All they need is, again, control of diabetes, good physiotherapy, rarely NSAIDs, and sometimes surgery if there is compression of the roots or the cord. Finally, the muscle involvement. Diabetic sarcopenia is something that we see nowadays, poorly controlled, and diabetic myonecrosis. Now, sarcopenia has now been related as a chronic complication of type 2 diabetes mellitus, and its reduction in muscle mass. There are quite a few patients who have very quickly, they lose the muscle mass and associated with decrease in muscle strength. It is 3 times more common in diabetes compared to general population. Associated with higher hospitalization, cardiovascular events, and mortality. It could be reversible through musculoskeletal rehabilitation, but I'm not sure it does the kind of rehabilitation that we do here. Yesterday, I think there was a talk on this.
The talk on sarcopenia.
Type 1 diabetes, spontaneous infarction, acute sub.
Hardik, what is the problem?
Sir, I think internet problem for Bidyut sir side.
Okay, then Bidyut, I would suggest Professor Chaudhary, if there's a problem, Bidyut, how many slides are left? Bidyut, are you listening? Bidyut? Can you ask on phone, Jayant or Surinder? I don't have Bidyut's number.
So can you hear me now?
Yeah, now you're clear. Yes, Bidyut, you are clear. I was trying to reach you, Bidyut. Yeah, how many slides are left? You can continue, no problem. Continue.
Last slide.
Last slide.
Can you see this slide?
No,
Not yet. Just start sharing.
Yes, just go.
I think it was disconnected. Yeah.
Yeah.
Last slide.
Now it has come, Bidyut. Now it is very clear. You can go for the previous slide to that, because that was very new thing which I also saw in Calcutta. But previous slide also kindly put Bidyut.
Previous slide.
Previous slide. That is a new entity, and I happen to see one in Calcutta. I'll show you.
Sarcopenia.
Myonecrosis.
Myonecrosis.
Fantastic entity. Yeah. Please start with this and then we'll finish.
So sorry, there was some problem, and I believe in Murphy's law. If something has to go wrong, it will go wrong. You can't do anything about it. That is Murphy's law.
Absolutely.
Even if I sit in telemedicine hall and with all facilities, gadgets, if something has to go wrong, it will go wrong. So diabetic myonecrosis this is a case I've never seen. I've seen all other cases. This is something I've never seen, and they come acutely, with swelling of the calf and thigh muscles because of infarction, and invariably they are treated as DVT or myositis because of the acute onset. There is increased CPK, ESR, CRP, MRI can help, but it's self-limiting. I have no experience on this, so I'll not be able to go further on this. Next. So what's the take-home message that we have? I've established from the very first case that I showed that we can miss these cases if you do not think about that diabetes and MSK can be closely linked. So there's widespread MSK affection in diabetes. And I just went through the different aspects, the soft tissue, the joint, the bone, and the muscles. Subclinical, if you pick them up at very early stages, associated with long duration of disease and poor glycemic control. That's the bottom line. And some of these people, if you help them, they can get very good quality of life. A majority of problems are soft tissue related and non-inflammatory. The first case had no inflammation. And I don't know why people still stuck to looking at inflammatory diseases and multiple myeloma, etc. A diagnosis is obviously based on good clinical assessment, not on all the investigations. I'm really amazed. I was amazed to see the kind of investigation that has been done on that patient. You just need good clinical assessment and a correlation that diabetes can present like this. These are the diseases that can occur. And good glycemic control, early diagnosis, that's all you need. And when they come to us, analgesics, partially they get relieved, the NSAIDs, sometimes their inflammation, because diabetes and inflammations are almost linked now. Physiotherapy is mandatory, which nobody does. No matter how much you induce them, they'll do it for 5 days, 7 days, and then they lose interest. They want dramatic results with medications. Local steroid injection in some of the conditions like trigger finger, all dramatic, they get response, very good response. And of course, if they come so late, sometimes surgery is what they require. Thank you very much.